Don't forget to record. Okay. So what I'm going to do is I made another little PowerPoint just because Dr. Beggart, he'll probably correct me. I'm sure I'm probably butchering his last name. But he's going to come in about 30 minutes. And so I didn't want to just fly through the PowerPoint. So I recorded one that you guys might have already listened to. And then I made another one that's just really highlights of what I want you guys to kind of pull out as some major points. So it's going to be repeated information from the other PowerPoint. So it's not new material, but it's just kind of highlighted for you guys. So this is stuff that's going to be potentially on quizzes and exams. So I'm trying to just bring out some major points just because I didn't know how long it would take me and I didn't want to feel rushed. And if anyone had questions or anything, I did want to say too, like about on the quiz that you guys just took, where there's side effects and things like that, you've probably all already noticed that when you look up a drug and you look up the side effects, sometimes they're categorized into mild, moderate, severe, or common, rare, like incredibly rare. They like kind of categorize them. And people, there are so many side effects that people experience, and they almost have to write everything down. If something gets reported and enough people have that, they record it. But I'm mostly gonna focus on like the first 4 or 5, or, even if it's a dental related thing, I might go a little further, like, because we want to pull out anything that's sort of orally related, like if it does cause stomatitis or mucositis or like lichen planus or something like that, or gingival hypoplasia, something that might not happen very frequently, but it can happen in the oral cavity. I'll highlight that even if it's a moderate, or kind of semi-rare, event, I would still kind of highlight it because it's important to us and it happens.
Leslie,
Yeah.
I have a favor to ask. Maybe it'll help all of us.
Mm-hmm.
Like, I know today all of us submit the assignment top 20, but can you like highlight the ones you're supposed to know for those? Because I used 2 resources and I kind of wrote all the side effects and adverse reactions.
Yeah,
So that
you
like
guys probably
tons
put
for
more than
every
you,
drug.
yeah.
Yeah.
You probably put and the point of that assignment is really not for you to memorize all of that stuff, because this is a memorization class. You do have to memorize a lot of stuff. It's a lot of flashcards. You're just going to have to do that. I mean, it just is. But the exercise of that top 20 was for you to get used to looking up drugs in a drug reference. So I wanted you to get used to what it looks like, what the format is. I'm sure some of you wrote way more detail than what maybe is necessary, but you didn't do anything wrong. You've helped yourself learn more about a very common drug that you're going to see in clinic. So you didn't waste your time. You didn't, it's good because you're using a reference and you're looking up information that you may need this year, next year, and whatever. So
But it's just too much information. I don't think, at least I'll be able to remember all of it. So how do we know what's important?
it's all important. And I can't
Okay.
tell you memorize these 5 drugs. That's what's going to be on the quiz. I can't do
Mhm.
that. Nobody's ever done it before me.
Okay.
Lots of students have gone through this, and I don't mean to sound harsh, but that is how it is. It's a heavy memorization. It's pharmacology. There's a lot of drugs, and you guys are gonna see a lot of drugs, and so you have to be ready. And so what in that line of thinking, Tasia, what I will do is I'll say, of the 30 high blood pressure drugs,
Mm-hmm.
focus on these 15. So,
Okay.
I mean, you guys know me already. I'm not just going to be like, good luck. So, I mean, I will I will help guide you, but I'll tell you right now, you're going to have to memorize more than what you necessarily will be quizzed on in my class, because you're going to see it in clinic, and then you're going to see it on the national board, and then you're going to see it come back in other, it's just always going to be there. I see there. I don't know if you guys are chatting me or chatting each
Yeah,
other.
I think I was talking about like the adverse reactions for each drug. Do we have to memorize all the 20 adverse reactions?
Okay, so when it comes to adverse reactions, it's a little bit harder because
Because they're all the same for
they're,
most.
yeah, I mean, xerostomia, count that for practically every drug that somebody takes. So there are going to be ones that are hit harder. There's going to be ones that you might say, oh, well, that's in this drug and that drug, but it might be more common. You know, there's going to be stuff that we really pull out is this is a common side effect that you're going to see a lot. It's not going to be something that's necessarily like super rare and obscure. It's going to be like calcium channel blockers, gingival hyperplasia. Like you'll just connect those, you know, and it's like anything does anything to cause sedation or it's a diuretic, or there's so many drugs that cause dry mouth, and you're just going to see it over and over again. So the things that pertain to dentistry are going to be really important. You're always going to want to know that. And that's going to be less. You're not going to have as much to remember, because there's just not going to be as many. But there's going to be things that if something affects bleeding, if it affects giving local anesthetic, if it can cause a manifestation in the oral cavity of something, all of that stuff is fair game. You just gotta know it amongst the drugs that we focus on in this class.
Leslie?
Yeah.
So I just have a question. I'm assuming we're going to have more quizzes like this, correct?
There is the next quiz. I think there are some more questions, but it's not necessarily like top 20 quiz. It's just like now you're quizzed on the pharmacology medications for the cardiovascular system. Now you're being quizzed on medications for asthma and COPD. Now you're being quizzed on medications for gastrointestinal system. So it's broken into those kind of systems.
Because I'm just wondering for like I don't know if you write the quizzes or not, but so like for example, the one where the key adverse effect that you want us to like make a star of is gingival hyperplasia. Could we possibly not list like xerostomia too, so that, because like for me, I'm someone that has a really hard time, even if I know gingival hyperplasia is more like out there, I'm gonna sit there for like 10 minutes and be like, I don't know which one to choose.
Well, I understand what you're saying, McKenna, but there aren't very many drugs that cause gingival hyperplasia, and that's a big deal. So if you see a drug that causes gingival hyperplasia and you know it's that drug, pick that drug. Remember, when you guys take quizzes and exams, it's the best answer. There may be answers that you could nitpick and go, well, this could be the right answer, but what's the best answer? And that's how it's always going to be. And that's how it's going to be on the board exam. It's always going to be that way. There's one answer that is like the best answer. And I mean, if the question is written bad and it's just like, well, that didn't make sense. I wrote that question too fast. There's room for there's room for discussion, but I don't want to make things unrealistically easy for you, because that's not going to help you guys in the long run when you go to take the national board and you're taking a 9-hour exam. You know what I mean? So
is there going to be a lot of on the board like up for interpretation questions like that? Because I suck at those. Like, how will I ever succeed at those? I don't know.
You'll do fine. But there are, because there's critical thinking, and critical thinking is kind of a little bit of subjective thinking. I mean, it's just like, okay, these are the elements. This is what I'm dealing with. What's the best course to take? So there are questions like that. But
I guess that's a frequent thing in dentistry anyways. There's like a lot of gray.
There is. You guys will find that in perio too. I mean, there's just a lot of gray.
Thank you.
Oh, I heard a voice.
Yeah. Can you hear me?
Yes.
Okay, I don't know why my volume is so weird. There's just in the chat, I think a lot of people are just maybe what Tasha was asking about, not like we know like we have to memorize, but like do you have a key to the assignment?
Yes. And so what I will say about that, because I think this could go on forever. I will post the key. I have it in there already. I just have to open it up. But when you guys look at my key, you're going to go, well, there's not very much information in there. But that's because what I want you to pull from the point of that assignment was not that you match every answer with my answer. The point of that assignment was to get you guys, because every medication that you see in clinic, you have to look up and write down dental implications and all that kind of stuff. And you guys already know that because you've already seen some patients. So our patients have a lot of, they take a lot of medications. They have a lot of, usually diabetic and heart disease. There's lots of stuff going on. So the main point of that assignment, as labor intensive and kind of boring as it might have seemed, was to just get you really familiar with searching medications, looking up side effects. So your answers are not necessarily going to look just like mine. But what I will say is that so I noticed that I've kind of gone through the PowerPoints and revised them a little bit, but like when this class was Amy's class, I saw she had a slide that said all top 20 drugs are highlighted in red. So those should catch your eye when you're, I didn't have them in red. So I can do stuff like that, or highlight, like I'll highlight the whole thing, like, look at this, because it might just be a question on a quiz or an exam. So I will do that whenever I can, or when, I can't just do that for everything. I mean, there's just a lot of material you just have to study. But I understand what you're saying is, how will you know what adverse effects to choose from when there's 500? Is that basically what everyone's saying?
I think everyone just wants a key so we can focus, like, because we know that we wrote a lot on our papers. So we want to know what to focus on, study for the test. We know it's going to be all the 20. We just want to know, like, what you want us to pull from that.
What are the most important side effects? Okay. Yeah. So let's go. Let me pull. Okay. So now we have probably 15 minutes or so. I think we have plenty of time still for me to go, because I only have like 6 slides. It's not that much. So
Leslie, I just had a quick question about the study notes that are due tonight. So I've almost finished them, and I was gonna work on them while we're lecturing today. But I just wanted to confirm which pages were due tonight, just because the section says cardiovascular, and then it says classification of drugs.
Yeah.
And then it says it's like 3 more pages, and then it's respiratory diseases. And I know that respiratory is next week, so it's like, is it all these like 6 pages?
Yeah, basically everything that's the classification of drugs, that page, if you look at some of the, like if you look at the questions, it's all cardiovascular. So everything there, you'll probably be able to fill in some answers from Dr. Beggert's lecture here in a little bit. So all of that, go all the way until you hit that respiratory diseases, then that's next week. So I think it's like 6. It's like 6 pages. I know it was a lot, but there's a lot in this chapter. It's kind of a heavy chapter.
Okay, thanks.
So yeah, it is. The first 2 pages are pretty much just on like the system, and then the rest are like on drugs, the drugs. Okay. So let me just pull up this. I have this in a funny space. Okay, can you guys see the PowerPoint? I didn't see anybody. Can I? Yes, okay. Sorry. Okay, so the cardiovascular system. So this is, like I said, this is a repeat of your the other PowerPoint, but I just wanted to pull out some key points since I knew we were going to have a little less time. So the cardiovascular system is essentially, it's the heart and then all the blood vessels around it. And what's the main purpose is we're supplying oxygenated blood throughout the whole body. But the system does other things, and you guys probably will see that more in detail on the other PowerPoint, like providing nutrition and helping with, there's, clotting factors. And then, so if someone starts to have an injury and bleed, then we have that clotting factor. And then there's also transferring all chemicals, hormones, drugs get transferred through the circulatory system to the different places of action. So the whole circulatory system does all kinds of stuff. But one of the main things, obviously, is sending oxygenated blood. So what could make the system fail? So there's two main things that could make the system fail. If your heart's not pumping, it's not going to get blood everywhere, right? It's just not going to get the blood to where it needs to go. So if it's not contracting sufficiently and it's not, actually pumping the blood, then that's one way that it would fail. And then the other is if there was a blockage and the blood couldn't flow through a certain area. And so we call that atherosclerosis if a blockage forms. And then cardiovascular disease refers to a variety of diseases of the heart. The ones that we kind of focus on is big one would be hypertension. Has a lot of drugs that we were talking about. Hypertension, angina pectoris, coronary artery disease, and heart failure. So those are sort of the major ones that we focused on in this section. So I pulled this. I know this wasn't in your textbook and it wasn't in the PowerPoint. I just put it up here because I wanted to just draw your attention to one of the major things that would be a contraindication. A lot of times if, so many people have cardiovascular disease now in the United States, it's, I don't know now if it's still the leading cause of death, but it has been. And so it's very common to get a patient in your chair with cardiovascular disease. And so, but oftentimes they're stable and they're maintained with medication. So a lot of times, as long as we know that they're taking their medication and we know that everything's in place, there's really nothing stopping us from treating that patient. So I just put this here. The main things that would keep you from treating a patient are, you notice the common denominator is uncontrolled or unstable. So unstable or recent onset of angina, something maybe a new development and they haven't stabilized yet and they're just working with their doctor to kind of figure it all out. Uncontrolled heart failure, arrhythmias, or a significant uncontrolled hypertension. Like in our clinic, if somebody is over our minimum for blood pressure, then we have to have a medical consult and we reschedule them. So that's kind of the common denominator. So hypertension was the first one we focused on. And what is that? So that's, you can think of, too much pressure, too much tension in the blood vessels. It's sustained pressure in the arteries. There's too much fluid, too much blood in there and not enough space. So it's putting a lot of pressure on the walls of the blood vessels.
Hey, Leslie,
yeah.
Did you not post this yet? Because I don't have this PowerPoint.
Yes, I haven't posted. I didn't want to confuse you guys and have you be like, why are there so many PowerPoints? So I was just going to go through it and then post it afterwards. Okay. But it says the same stuff really as your other one, but I am going to post it. So normal blood pressure is less than 120/80. So we always thought, 120/80 is normal, but we actually want it to be less than 120/80. And people can have sustained high blood pressure for many years and not even know it. It can be asymptomatic. And so that's why a lot of times they call it a silent killer, because it actually doesn't always manifest itself in noticeable things that people can complain about or that would send them to their doctor. And that's why so oftentimes when we do our blood pressure screening, if patients don't go to their doctor on a regular basis, but they come and get their teeth cleaned, we take their blood pressure at every visit and we can say, hey, Joe, your blood pressure has been high the last 3 times. Don't you think you should get that checked out? Because so often they'll say, oh, that's just because I'm at the dentist or something like that. But it could actually be a condition that needs treatment. So the difference between systolic and diastolic, so systolic pressure is the pumping or contracting of the left ventricle, forcing blood out. So blood is going out to the body. And then diastolic is when everything's relaxed and it's kind of flowing back in. So when I was in school, they used to say that if diastolic was high, that was the thing that was really like serious. It could lead to heart disease and heart problems. But what I just read recently was now they're looking more at the systolic. So if the systolic is consistently high, that's more the precursor to what they think could be a complication for more heart disease. So that's changed over the years, but one is kind of, you'd expect pressure because it's working hard, and then the other one should be relaxing. So diastolic should be relaxing. So then there was a question about what receptors are regulating blood pressure. And so I just put this in here just for another reminder. So alpha 1 is smooth muscle. And so that's going to be the blood vessels. And then beta 1, remember your heart, you only, what did we say? Your heart beats one, you only have one beating heart. Oh my gosh, I was like, what did we say? You only have one beating heart, beta 1. So beta 1 for the heart and alpha 1 for smooth muscle, which is the blood vessels. Sorry, get rid of that. So factors that influence blood pressure. So 3 main things for you guys to remember that influence blood pressure is the blood volume, the amount of blood volume that can be affected by if they're retaining fluid or retaining too much fluid retention or loss. So like dehydration and things like that, there'd be less blood volume. Retaining fluid, that there'd be more blood volume. And then peripheral resistance of the actual blood vessels. So that's going to be affected by the central nervous system activity. So with the adrenergic receptors and the sympathetic nervous system, that's going to affect the peripheral resistance. Renin comes from the kidney. So, and we'll talk about that. Actually, we won't talk about that now, but if you listen to the recording from the PowerPoint, I talk about that. So make sure you listen to that recording of the other PowerPoint that's in the Moodle page. And then angiotensin 2 activity also has to do with the peripheral resistance. And then cardiac output, so the stroke volume, how hard the heart is contracting, and then how fast also, the heart rate. So those are the 3 main factors of the influence blood pressure. So this system on the main PowerPoint for this class, this RAS system, it's renin, angiotensin, aldosterone system. And on your study notes here, it says, what are the major organs that are involved? It's the liver, and then the kidneys, lungs, and adrenal gland. And there's a great video that's embedded in the PowerPoint that I highly, highly recommend that you guys watch because that really, they describe the system really nicely. So you'll be able to see the flow of how the hormones turn into angiotensin 2, which directly affects blood pressure. So make sure you go into the PowerPoint and watch that little YouTube video. And then I wanted to highlight atherosclerosis and what it is. That's another question on your study guide. So what is atherosclerosis? It's basically plaque or a fatty deposit that builds up in the arteries. And this, the deposit is made up of cholesterol. It's made up of fatty substances, cellular waste, calcium, and fibrin. It's a clotting material. So there's different stuff that build up, but mostly we kind of worry about the cholesterol. We think about it as cholesterol, but there's other things. But it's a plaque that builds up on the walls, and it makes the lumen or the opening of the blood vessels smaller and smaller as the plaque builds up. And so then it talked about, well, what is cholesterol? So I wanted to highlight the different kinds of cholesterol. So there's low density lipoprotein, that's LDL, and we call it the bad cholesterol. And then this cholesterol is considered the bad because it contributes to the buildup, and it mostly carries it. So LDL mostly carries cholesterol through the blood, And then HDL, high density protein, we call lipoprotein, we call it good cholesterol because it kind of helps metabolize the bad stuff. And so it carries it back to the liver where the LDL is broken down and passed out of the body. So this HDL kind of helps clean up the system. So if somebody has high bad cholesterol and low good cholesterol, their body is not getting rid of the cholesterol. It's not metabolizing the cholesterol very well. It's not bringing it to the liver to be metabolized and then excreted out through the body. And then vice versa, if they have low LDL and high HDL, then that's a better situation to be in. So our cholesterol medications help to adjust this. Okay. And then to highlight angina pectoris, this is a medical term for chest pain or discomfort due to coronary heart disease. And it has to do usually when there's a restriction, there's not enough oxygenated blood getting to an area and causing this pain. So it can feel very much like a heart attack. It can radiate down the arm and up the neck. And it's because everything's kind of narrowed, or it's or maybe a blockage. And so and it's also called ischemia when that happens. So that's what's happening if someone's exerting themselves and they're not getting the oxygenated blood they need because of the narrowing, then they can get this pain. So normally the type of chest, this kind of chest pain is relieved with nitroglycerin or nitrates. That's one of the more common drugs that you'll see somebody take when they have an angina attack, and it relaxes and opens up the blood supply. So congestive heart failure, so the purpose of the heart, like we said, is to pump blood, to get it oxygenated blood through the system in order to nourish it. So heart failure doesn't mean that the heart has stopped working. It just means that it's not pumping. So remember that congestive heart failure, it's not pumping well. It's not acting like an effective pump and not getting enough blood to where it needs to go. I think I'm looking at the clock. And I want you guys to have a 5-minute break before we do our next segment. So I think there was a little bit more to read through. These are some dental hygiene applications. These are, I think I spelled that wrong. These are some highlights of hygiene applications that will be very key, specific key points that you'll want to remember that you could possibly be quizzed on. So just kind of read through these and make sure, like the max number of cartridges of local anesthetic for a patient with controlled hypertension, 2 cartridges. You can use that pretty well with most cardiovascular conditions. We usually cap it at 2. Okay, so I'm actually going to stop there and give you guys a 5-minute break, 7-minute break. Yeah, 7-minute break. Come back at 2:50, and then we'll hear from our guest speaker, okay? Oh, I think I see. Hi, Dr. Beggart, are you there? I see your picture. Oh, he's coming. Okay.
how math equations work right now. If we drop either cardiac output or if we drop peripheral resistance, that's going to lower arterial blood pressure and hence lower the blood pressure. And so I kind of like to think about that. And this is a useful equation to think about too, if you ever go diving deep into heart failure management and how heart failure is really dependent on cardiac output and those components within this equation. This is a very long, big, complicated structure, and I think you guys have a video to watch about the RAS system that will probably do a better job at kind of highlighting these pieces that I'm going to talk about here. But really, I like this photo because it goes to show how the RAS system pretty much plays a part in every aspect of blood pressure regulation all throughout the body. You know, you see that at the basis here at the start, we're really just talking about our angiotensinogen or angiotensin 1, angiotensin 2. And then from then on, we're touching everything throughout the body, whether it be in the kidneys and aldosterone secretion and water retention, which is going to change peripheral volume, which when we increase the volume, it increases the resistance and increases blood pressure. Our sympathetic tone, which is our norepinephrine, epinephrine, that's going to impact heart rate, that's going to impact cardiac output, that's going to impact blood pressure. So you can see how this one central mechanism here at this ACE enzyme, how inhibiting this or blocking this angiotensin 2 is really going to have a favorable effect on impacting our blood pressure. And in the favorable, I'm meaning dropping the blood pressure. So you can see how this is a very central system within our body for controlling blood pressure. And so that's going to be some of the main medications that we discuss. But the first one I want to start off with is probably some of the most common agents that you're going to see, some of the most long-standing, longest used medication classes for blood pressure, and that's our diuretics. And so these are working primarily in the kidneys, and diuretics, diuresis, you would assume we're losing water. We're going to be letting off some of that volume through our urine. That will decrease our plasma volume and decrease our resistance and lower our blood pressure. Now, we have a lot of different diuretics that we use, and they don't all have an indication or a place in therapy for blood pressure. But the first two I have listed here are thiazides, and the most common ones you'll probably see are hydrochlorothiazide or HCTZ or chlorthalidone. And you might see chlorthalidone being used more and more and more as time goes on, as that one is actually shown to be more beneficial for morbidity and mortality reduction than HCTZ. It just so happened that HCTZ kind of got a foot in the door first, and more people are comfortable using it, but it's actually probably more appropriate to use chlorthalidone. Either way, they're the same class. They work in the same place within the kidneys, and those work very well at lowering blood pressure and are often a common first agent that people use. Loop diuretics, on the other hand, these are very, very effective diuretics, more effective than thiazides at letting people lose fluid. But we don't use them more commonly for blood pressure management. We more commonly use them for edema or swelling, and in patients that have heart failure. So if you see a patient, or if they talk about, I have a diagnosis of heart failure, you might likely see furosemide or Lasix on their med list. Still going to be diuresing, still potentially lowering blood pressure, but a different indication for use. And the same thing for the potassium-sparing diuretics in spironolactone. That's more commonly either used in heart failure, so it does reduce mortality, which is always a plus for patients that have heart failure, or in a patient that has resistant hypertension. So they're on lots of classes of medications and you kind of run out of options. We see spironolactone getting thrown on there. Not so great at diuresing, but it does lower blood pressure as well. So now, when we talk about diuresis, the main thing, and you guys probably all know this, where salt goes, water follows, right? And vice versa, where water is going, salt is going. That's a main electrolyte in our body. It's important for a lot of cellular function. Well, when water goes, salt follows, but as does a lot of other electrolytes. So that's the main thing that a lot of what we need to monitor for when we're focusing on these medications aside from vitals are electrolyte imbalances, which can impact people in different ways, especially if somebody's an elderly person. They can really respond negatively to some electrolyte imbalances. The main thing to focus on for you guys is they could develop a lichenoid reaction in the mouth. This is the first class that we're going to talk about for this indication or concern, but there's multiple classes that have this concern. And this could develop at any time throughout the treatment. Doesn't happen right off the bat. But if they do start developing this reaction and they don't have some other immune response or some other immunologic reaction, or they don't have dental implants or something that's causing that reaction, it may be the medication. They may need to stop, and if they stop it, it usually goes away. If not, they can treat with steroids or things like that to maybe lessen the response that they're seeing. But that's our diuretic class, and really the main indication there. I'm going to talk about overall indications as well for these classes or concerns dental wise. One of them being we're lowering blood pressure, dizziness and orthostasis and all that stuff is going to be a concern for all classes of medication. So we'll kind of recap all classes and kind of lump them all together for some general considerations at the end. Any questions at this point about thiazide diuretics? Or diuretics in general?
I had one question.
Yeah.
Is the lichenoid reaction caused by electrolyte imbalance, or that's a separate reaction?
That, as far as I would know, I don't think there's a connection there. It's a more of a like an immunologic type response to the medication causing this reaction. Electrolyte imbalances is just purely from like the diuresis that's occurring. So they're two separate things. Good question. Any others? So the next class of medications that I'm going to talk about, I guess more and more now are used less for blood pressure and more for other indications, but we have is our beta blockers. And there's some interesting implications for dental, so that's why I'm kind of talking about it earlier on. But these are agents that are going to be looking at that cardiac output component of that equation. So figuring out how to lower that cardiac output, and that's done by lowering heart rate more often than not, or impacting resistance to peripheral resistance, depending on your beta blocker that you're using. And that's going to lower our blood pressure. So we have a bunch of different types, and we've already talked about beta 1, I heard. So we got beta 1 receptors, we got one heart. So it's easy to know that the cardioselective beta blockers work at beta 1. And those, there's more than this, but commonly you might see metoprolol or atenolol. I'd say most common is going to be metoprolol. And that's probably going to be this toprol version or toprol XL, which is the once daily formulation. And is the one that's indicated for use in heart failure. The non-selective options that we have, again, we have many of these, but propranolol is probably the most common one you'll see there, or Inderal XL. And this is used for blood pressure, can be used for blood pressure, but you might also see it used for a lot of other indications, possibly migraine prophylaxis, stage fright, generalized anxiety. So lots of different indications that you might see being propranolol used for. So it's good to get a good history about why somebody's taking their medications or what their problem list is, to know for sure and not assume that a medication is prescribed for say heart failure or hypertension. And then we have our mixed beta blockers and alpha blockers. So carvedilol is going to be the most common one there, and another approved one for heart failure management. And then labetalol, less commonly used, but you might see being used in somebody that is pregnant. It is one of the more preferred options for pregnant females. And as far as dental implications go, this was already discussed a little bit as well about epinephrine and being concerned about beta blockade or not giving too much epinephrine. And that's kind of where I'm focusing on here is you can become more sensitive and potentially, in rare instances, develop a hypertensive urgency or crisis with too much epinephrine if somebody's on a non-selective beta blocker. It has to be non-selective. I say that with a caveat in that if you dose a selective beta blocker high enough, it's non-selective at that point. But that's getting kind of into the weeds there. But more often, non-selective beta blockade could rarely cause some hypertensive urgency. So I have some slides here that kind of outline that a little bit better for you. So we've got our epinephrine floating around here, and we have our different receptors. We know beta 1 is in the heart. We know beta 2, or you might know, but beta 2 is in the lungs. And that's easy to also remember in that one heart, beta 1, 2 lungs, beta 2. And then we have alpha receptors, which was already mentioned is responsible for smooth muscle contraction. And that's largely, it's in many places, but in terms of what we're talking about here, in the vasculature. And so when we have activation at these receptors, beta 1 with epinephrine is going to increase heart rate and contractility. Beta 2 is going to dilate those bronchioles, open up those smooth muscles. Can you guys think of a beta 2 agonist that might dilate lungs and improve breathing?
Albuterol?
Yeah, albuterol. So very common beta 2 agonist that we use in patients with asthma or difficulty breathing to open up those lungs. And then also, so works similarly to epinephrine, just different structure. And then if we hit alpha 1, we see vasoconstriction. And so you'll see a lot of dilation and constriction, and really those are balancing out. They're playing with one another to kind of maintain blood pressure homeostasis. Now, when we start blocking one and opening up another, that's where things become out of balance. And so if we throw back our epinephrine here, but now we cardioselectively block beta 1, as in our what we do for heart failure or in post-MI patients, we slow that heart rate, but we still see a nice balance between beta 2 and alpha 1. So the blood pressure is fairly regulated in that beta 2 is relaxing blood vessels, alpha 1 is constricting. Now, if we throw non-selective in there, we might see some impact on heart rate, which we do, less so than with a beta 1 blocker. And we see some impact at other beta 2 receptors, and in some instances, not favorably for blood pressure management, hence why propranolol is often not used strictly for blood pressure control, even though you do see some blood pressure reduction. And then you see alpha 1 receptors just kind of going on and doing their normal thing. Now, this isn't to say that if I use a propranolol, my blood pressure is going to go up because we're activating alpha 1, but blocking beta 2. That's not what happens. But this is where the concern rises for epinephrine, in that if you give a high enough dose of epinephrine while you're blocking this beta 2 receptor, then you can have too much unopposed constriction at that alpha. You flood those receptors, and so that blood vessel that was doing just fine with that propranolol alone now could go much smaller. And just like a pipe or anything else, smaller diameter is going to need more pressure. And in some instances, that could be significant increases in systolic blood pressure, 200 or higher. Now, again, I say this is rare. And in some instances, patients have reported, and you may have more experience with this than I, Leslie, of somebody giving epinephrine, and they may have a headache. They may experience maybe some chest tightness or something going on. It's not severe, it's slight increases in blood pressure. They may note those symptoms, but they're not so much an emergency. I don't know if you've had that happen to you before.
I just get a lot of, when I was in practice, patients would feel like a little heart, like, like a little heart fluttering, and then it would go away after a minute or two. Mm-hmm. But I don't remember anyone ever saying that they had that, but maybe they just didn't mention it to me.
Yeah, I mean, it's pretty non-specific. It could be anything. People might attribute it to stress-induced at the dentist, any number of things. But if they do start experiencing significant chest pain, significant headaches, anything like that, that would be suggestive of a stroke or a heart attack, you might check their blood pressure, just see where it's at. But like I say, the doses of epinephrine are usually small in that setting. that we don't see a lot of concern for systemic exposure. But always good to look at that med list and see, do I see a propranolol on there or some other non-selective beta blocker, and what might that mean? Any questions for the beta blockers? And I forgot to mention, all of these end in -olol. So there's some drug classes that are really easy to remember, beta blockers being one of them, others maybe not so much, but this is one of those.
I did have a quick question. Sometimes when I was working in perio, we would do a lot of SRP, so a lot of anesthetic, and I would do their blood pressure before and after I was done. So sometimes their blood pressure might be slightly elevated before I started, which they could have been hypertensive or maybe they were nervous, but then sometimes their blood pressure would be lower at the end. So I thought, well, maybe they're just relaxed, it's over with. But does it actually, because it's, working on different receptors, is it possible with certain to actually end up with like a little lower blood pressure after the anesthetic?
Yeah. So the epinephrine is one component, but the anesthetic itself could definitely cause a lowering of blood pressure, for sure, depending on which one you're using. So I know that the epinephrine is used to like increase access, right, and improve absorption, or maybe localize where it goes. I can't recall the mechanism for why it's added, but the anesthetic itself could definitely cause that effect, for sure. Mm-hmm. Similar to like how what is the term for them? They help the physicians that put people under. They sedate people during
anesthesiologists.
Anesthesiologists.
I'm like, I'm trying to think of the
word. They have to be really closely monitoring those vitals because they can really drop people with those that if they're not careful. Mm-hmm. Right. So now we're returning back to our RAS class and that RAS picture. And we're going to talk about ACE inhibitors. And by far the most common class, I'm jumping ahead of myself here, the most common class of RAS inhibitor that you will see. They've been around the longest. So the PRILs, the ACE inhibitors, the common ones that you will see are listed there. Again, this is not an all-inclusive list. They are working, as the name implies, by inhibiting the ACE enzyme, which is angiotensin converting enzyme. So stops the production from angiotensin 1 to angiotensin 2. Angiotensin 2 is that active form that then goes downstream and has all those effects in the kidneys and the sympathetic nervous system and so on. So if we can stop angiotensin 2 production, then we don't have those effects that impact blood pressure. So this is basically kind of a pictorial representation of what I just said. And so we keep that inactive form there. So again, we're going to lower blood pressure. So there's always something to pay attention there. How low are they going? Are they having any dizziness? That type of stuff. Not so pertinent to dental, but definitely the main thing we monitor for when we're prescribing these medications is the potassium level. This has a tendency to retain potassium, and in some instances can be pretty significant. And if we get too high potassium levels, we run the risk of arrhythmias developing in patients. Should not be used in women of childbearing age or those considering pregnancy or are pregnant, in that it can impact the little fetus kidneys. It works in the kidneys by constricting various arterioles, and so that can overconstrict in a fetus and not be good for their little tiny developing kidneys. Dry cough may be something that somebody might has to do with the mouth. They might be commenting about a cough if they see you. This is due to the fact that when you inhibit this enzyme, another thing is produced called bradykinin that builds up in the system and causes this dry hacking cough. Doesn't mean they have dry mouth. It doesn't mean they're sick. It just is bothersome, rather annoying. Over time, though, if they can wait it out, which is always hard to recommend for a patient when they're upset about a side effect of a medication, it usually goes away. One thing, again, that pertains to the mouth that is a significant but rare side effect is angioedema. And so this is more commonly seen in African American patients, but can happen in anyone taking this medication. And this is, again, a result of bradykinin buildup and results in basically what seems like an anaphylaxis and a significant swelling of the face, mouth, lips, and throat. So this is not the best picture. To be honest, I think this guy is just sticking his tongue out farther to make it seem like angioedema. I need to change it for next year. But it can be much more significant. Big swelling all around the face. It seems like, somebody might have got stung by a bee and is having an adverse effect. Again, it's rare, but if somebody's having this, that's an emergent event. They would go in, likely get intubated, steroids, antihistamines, stop the medication, and then not start it again for fear that it could redevelop. But that's definitely the most significant but rare adverse effect. I've never had a patient that I've started on an ACE inhibitor have angioedema. I have had a few that had it as an adverse effect or allergy on their list, even though it's not a true allergy. So definitely can develop. Now, if they do have one of these symptoms, or maybe can't tolerate an ACE because of a cough, we have another class to consider in the ARBs. And so these end in sartan. So again, easy to remember, many more than the two that I have listed here, but losartan and valsartan might be the more common ones that you see. Most definitely losartan probably. And these work a little bit farther downstream. So they let ACE do its job. Angiotensin 2 is created, but instead of letting it absorb or go to that receptor and then have all those downstream effects, we are going to block this receptor. Hence, ARB stands for angiotensin receptor blocker. And so now angiotensin 2 is just going to go boing, bounce off, have no effect. But the two medications, just working in a different place in the line of things, basically have the same effect of lowering blood pressure, possibly having an increased risk or concern for potassium retention. But the big difference is we don't see bradykinin develop because we're not inhibiting this enzyme. And that bradykinin led to the cough, led to the angioedema. And so there's less of a risk for them developing those if they've had a history with an ACE inhibitor. There is some potential concern, even though I don't think it's very validated and it's very low risk, that there's some cross-reactivity between ACEs and ARBs if you do have a reaction, but that's not very clinically relevant. But the other side effects are pretty much the same between the two classes. And these are, again, used for hypertension management, but also used first line for heart failure, first line for patients who have had a heart attack, patients who have chronic kidney disease, and that it helps slow the progression of CKD, in patients with diabetes that have heart failure and kidney damage. So there are lots of indications that you will see an ACE inhibitor or an ARB used. And that is because if you reference back to that image, there's so many downstream effects that these classes touch and benefit. What questions are there about ACEs and ARBs? Make sure I'm doing okay on time. So our last main class for blood pressure management, oh, there's one. Are they both in the RAS category? Yeah, they're both considered RAS inhibitors, like because they're working within that pathway, definitely. Yeah, so our last class of hypertension managing agents, also could be used for other indications, are calcium channel blockers. And so we have two types here. We have our dihydropyridines, which end in pine, but it's pronounced peen, and our non-dihydropyridines. So the easy ones to remember are the DHPs, because they all end in that pine, peen spelling. Non-DHPs, they're all over the place, but we have verapamil and diltiazem. There are more DHPs than are listed here, but these are the non-DHPs that you will see. You'll just see various brand formulations of these, which makes it incredibly confusing and unfortunate. There's like 10 different formulations of both of these formulations, verapamil and diltiazem. Either way, Cardizem, Calin are common brand names. And so these are, oops, sorry, go ahead here. These work in the vasculature, so they open up the blood vessels. And if we think about cardiac output times peripheral resistance, this is lowering our peripheral resistance. The non-dihydropyridines have the additional benefit of also, or the additional mechanism of also reducing heart rate. So working like a beta blocker would in reducing how fast the heart rate beats and how hard it is contracting. So there's slight differences there. Both of these, you're going to be keeping an eye on the blood pressure, but you're going to be keeping a closer eye on the heart rate as well when you using a non-DHP, because those are slowing the heart rate down, whereas the DHPs don't impact heart rate at all, or if anything, they might increase it slightly. As far as dental implications go, outside of dental implications, these are rather well tolerated. The DHPs are my favorite medication to prescribe for hypertension management. They're a first line agent for blood pressure management. And then on top of that, my patients, often low income, uninsured, don't have a lot of money to order labs and things like that. You don't have to monitor electrolytes. You don't have to get blood work with these medications. You just have to keep an eye on your vitals, your blood pressure and your heart rate. And that's done for free with a blood pressure cuff and your fingers on your wrist. So pretty cheap there. So I like to use this if patients can't afford labs and things like that. So monitoring is pretty straightforward. As far as dental implications go, gingival hyperplasia is, it's not common. It's also not like as rare as some things, right? So greater than 10% of patients, that's a pretty significant number. Now, again, I haven't seen patients, but I have seen in their chart where they did develop this and had to switch off. And so if they do develop gingival hyperplasia, the treatment is to just stop the med, and over time that usually recedes. Some instances, severe cases, they may need surgical resection of the growth, but more often than not, it will go away. And more commonly seen in the DHPs, but can be class-wide. Nifedipine is a kind of frequent offender for causing this compared to some of the others. But fortunately, nifedipine is maybe not used as frequently as amlodipine would be. So maybe a lower risk or less commonly seen nowadays. So that's the big dental implication there. But I love this class. It's a good class. And again, first line for blood pressure management. Those are, and again, we'll talk about these again later, but we used calcium channel blockers for other indications as well. Stable ischemic heart disease can be used in heart failure. So there's a lot of crossover beyond just blood pressure management. So again, just some of those general overviews as pertaining to blood pressure. You always got to be paying attention to dizziness and orthostatic hypotension, especially for you guys where a patient's been laying down for who knows how long, depending on what's going on. If they're on blood pressure medications, especially if they've just started an agent, then they may be very susceptible or sensitive to changes from a lying to sitting down position. Those that are on a beta blocker may be even more sensitive, because one of the main ways our body combats orthostasis is an increase in blood pressure. The baroreceptor sees a drop in blood pressure and instantly the heart's like boom, 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 beats faster. But if they're on a beta blocker, we've slowed the heart rate, it responds slower, and they might not respond as well to a rapid increase or a rapid change from laying to upright position. So beta blockers are common to be seen with orthostasis, as well as another medication class that I didn't talk about, alpha blockers, which can be used for blood pressure, but are more commonly used for people that have BPH or prostate issues. That can also cause orthostasis. And so just important to let them get up slow, take their time, so you don't have somebody on the floor when you come back to the room. NSAIDs may counteract antihypertensive effects. And so that's going to be a big one because you guys are doing operations, having procedures where afterward there might be some pain. So, give them an NSAID, naproxen, tell them to take some Tylenol. But if it is an NSAID, particularly with ACE inhibitors and ARBs, they counteract the activities of an ACE inhibitor in the kidneys. ACE inhibitors and ARBs dilate, where NSAIDs are vasoconstrictors. And so you see a loss of antihypertensive effects. Now, short term, not really going to be an issue. Long term, though, this is where it starts to compound. So if they're just taking it for a couple days for some pain management, it's really probably a moot point. But if they start taking it chronically, they may need to see their blood pressure medication adjusted. And then again, the oral lichenoid reaction. Am I saying it right? I think somebody else said it a different way. Lichenoid. Okay.
Yeah. Lichenoid. Mm-hmm.
And so, like I said, most common with diuretics, but you can also see it with ACEs and with beta blockers. And so if it comes up, it could come up at any time. It won't probably be within your scope to say, stop this med, but you might reach out to the clinic provider and say, hey, this is going on. This could be a potential cause. And a provider might not have that connection or make that association in that they don't usually work in the mouth or maybe think about that. So it's good triaging there. All right. So we're moving away from hypertension management. Going to see a lot of common drugs, but do we have any questions before we move on to ischemic heart disease? All right. Again, feel free to use the chat as they come up. So ischemic heart disease, coronary artery disease, you're going to hear it called a number of different names. It's all the same thing. And basically what we're talking about here is we have angina, where we have chest pain, heart discomfort, and we are not meeting oxygen supply and demand. So the demand is up, the supply is down. That's the easiest way I can think about it. If you think about those Libra scales, it's like this being demand, this being supply. And so we got to try to balance that out. And we got to try to supply the heart with oxygen. And so it was already discussed how that's done. And that's usually with nitrates as one direct method, as vasodilating the arteries to get the blood flow up to a more adequate level to supply oxygen to those muscle tissues. But we can also use other classes that we've already talked about, beta blockers being one of them, and dihydropyridines, which either lower the heart rate, or non-dihydropyridines, because they lower the heart rate, which decreases oxygen demand, or they vasodilate, which allows more blood flow to the heart, which increases supply. So either of those modalities can be used in addition to the nitrates. So we're not going to recover the calcium channel blockers and the beta blockers because there's nothing different. We've already talked about them. Sorry, I forgot I had fancy images here. But we will talk a little bit about the nitrates on the next slide. And again, a lot of what's happening here is just because of atherosclerotic plaque has formed in the coronary vessels and decreasing blood supply. So they get that chest pain. So we have our nitrates. We have nitroglycerin, we have isosorbide mono and dinitrate. So those isosorbides are long-acting nitroglycerin that they can be taken daily, as opposed to nitroglycerin, which is usually as needed as somebody is presenting with signs of angina. And so the patients will usually have a little vial, like a little brown vial with tiny tablets in there that are sublingual nitrate tablets that they'll throw in their mouth when they start having symptoms of chest pain. And then hopefully that resolves those symptoms. Historically, the recommendation was patients can take up to 3 doses of nitrates before they call 911. If they haven't had those symptoms resolved, then they're probably having a heart attack or they need to have some more aggressive treatment. That recommendation has kind of gone away, and now they usually recommend or prefer patients call 911 after the needing to take 1, and then they can take up to 3. Now that's not done by most, but the reason why they're having chest pain is because they don't have oxygen supply. When you don't have oxygen supply, that means you're killing muscle. And if it gets far enough and worse enough, that's what turns into an MI or myocardial infarction, which is deadly. So they're really trying to cut down on severity of heart attacks and to not just push aside, oh, I'm just having a little bit of chest pain, it's fine. It's probably not. It's not good. So you should seek help. So they may be taking it as needed or daily. As far as dental considerations go, when they do take it, they may get a headache. Most people like that sensation or that feeling because then they know it's working, because it causes a significant and rapid vasodilation effect and a drop in blood pressure. And so say somebody is having an event, or not an event, maybe an event, but angina in your chair, and they have their nitro and they take it, you're definitely going to want them to get up really slow. They should probably just lay there until they maybe get medical help, but not have them get up too quickly because they might definitely faint. And then nitrates, more so the PRN nitroglycerin, but it could also happen with the long acting, as you may experience some pretty significant dry mouth, which could lead to a lot of dental problems down the road. One other note to mention about angina is angina. I go back and forth with my terminology here. But you guys know probably better than most about the anxiety that patients can feel around a dental chair. And when a patient's heart rate is rising and escalating and they're nervous and scared, that could bring on a symptom of angina potentially. And so it's always good that they have the nitrate tablets with them, that you hopefully inform them that they should have them with them, and that you guys are also as calming as you can be so that they aren't nervous, so that they don't have any of these symptoms develop while they're in the chair if they do have a severe form of anxiety. And if they do, their provider may work with them for something similar to like propranolol or something that might work with stage fright to slow that heart rate down and kind of prevent those symptoms from developing. So just something to keep in mind. You don't want to cause somebody to have a heart attack. No, I'm joking. And I already mentioned that other agents used like beta blockers or calcium channel blockers can also be used to improve blood flow to the heart. So I just have one slide on that disease state. Any questions on ischemic heart disease? See some shaking heads. Oops, now I'm going too far. So the next class or disease state we're going to talk about is lipid management. Again, you've already talked about lipids, the good and the bad. We're really primarily focusing on reducing our LDL cholesterol with these agents. And the most common by far that you are going to see are the statins. And again, these ones are really easy to remember in that their name is also in each drug name and it ends in statin. So atorvastatin and rosuvastatin or Lipitor or Crestor are probably going to be your most common ones that you see because those, in managing of lipids, we look to using high intensity or moderate intensity statins, and these are the only two that come in high intensity forms. So if patients need more aggressive LDL lowering, those are the two classes that we usually go to. These work in a lot of different ways, but mostly reduce LDL and total cholesterol. They do increase HDL, which is our good cholesterol. So we don't know how that translates into outcomes, but we like to say that it can't hurt. And it also reduces triglycerides, which does have some atherosclerotic properties to it. And also, if patients have high triglyceride levels, severely high, they're at risk for pancreatitis. So we can get that down as well. Really, as far as dental implications, to be honest, I really couldn't find any. And to be honest, there isn't a lot of monitoring that we do for these classes besides lipids. Is their lipids going down? If they are, that's good. That means they're taking them. And now we just want them to get to a certain goal. The only other side effect that we usually monitor for are myopathies, as you can develop some rare but significant, potentially fatal rhabdomyolysis in some instances for patients taking this medication. But again, there's got to be a lot of other things that happen before somebody develops that with a statin. So overall, pretty well tolerated. You might see it on a med list. And if so, to be honest, they could have any number of things. And some people argue that they should just put these in the water, because eventually guidelines continually move age ranges down at which people should start statins, or when they might see benefit from statins. So they could just be on it and not really even have any very significant cardiovascular disease. Same thing with metformin for diabetes management, which you'll probably talk about later. Everybody seems to be on that as well. All right, so the last kind of conditions we're going to talk about are clots, or at least how to prevent clots from forming. Those are what lead to our heart attacks, our pulmonary embolisms, which are blood clot forming in the heart, or strokes, or DVTs, blood clots forming in the extremities, and causing potential amputations or other problems. So we don't want clots at all, really, in our body. So we try to prevent them whenever we can. Oops. And so there's lots of different clots and ways that they can form. So I'm not really going to go into whether or not it's in the arteries versus the veins and how that might lead to different formulations. But basically, we're just trying to prevent platelet aggregation in some way, shape, or form with our antiplatelet medications, or with fibrin fibers from developing, which will bind to those platelets and then form that clot. So there's a couple different mechanisms at play. And so we just try to prevent those things from joining up whenever there's an injury in the vasculature or some type of turbulence. So again, if somebody has some type of a mitral regurgitation or something in the heart, or the blood is circulating in a manner that's not normal, the platelets can stick together when it's very turbid and cause a form a clot at that point. So if anything's going on like that, we either give an antiplatelet or an anticoagulant. And so the most common antiplatelets you're going to see are aspirin. It's been around for centuries, and clopidogrel or Plavix. And so you may see them being used simultaneously. So for example, if a patient has had a stent placed, they may be on dual antiplatelet therapy for up to a year or longer. So don't be alarmed if you see two antiplatelets together. The only thing there is that they definitely are not going to have platelet aggregation, but what they most likely may develop is bleeding. So we have now two agents that are inhibiting platelet formation in different mechanisms. And so those two combined increase somebody's risk for bleed, also decrease somebody's risk for clot formation. And so it's just something to be in mind, and they may be asked to stop that medication, but more often than not, most dental procedures are minimal. Most dental procedures, the benefit of stopping the antiplatelet or the anticoagulant does not outweigh the risk of bleed. So it's usually more beneficial to maintain that medication, because if you stop it and then a clot forms and they have a stroke or a heart attack, that's worse than trying to stop bleeding. Warfarin is, historically our most common anticoagulant, and I would say it is still the most common anticoagulant out there, but it is losing favor really quickly in terms of what we prefer to use, which will be the other classes of medications we talk about on the next slide. But this is kind of been our mainstay at anticoagulating folks after if they've got AFib, for example, common indication for needing chronic anticoagulation management, or if they've had an unprovoked DVT or pulmonary embolism, so a more significant or severe clot formation that needs a little bit more than just antiplatelet therapy. You might see warfarin implemented, or Coumadin is the brand name, which is the brand name. One of the big reasons why lots of people are going away from this is, one, it requires INR testing pretty routinely, which is a pain. If you haven't heard about that, it's getting your blood tested to see how coagulated you are. And it's also very sensitive to diet and other interactions. So if patients eat a lot of green leafy vegetables, then their INR will go down and they're at a higher risk for clot. If they take it with other medications, if they drink alcohol, there's a list that's just innumerable, and why you have to get such frequent tests, as opposed to the other classes that we'll talk about, which have less interactions. But again, bleeding is going to be your main concern here, and even more so than with your antiplatelets, as we are working in a different location within the clotting cascade, and so have greater risks of bleed. And well, depending on where you look, you might actually see aspirin and warfarin have the same level of bleed risk. It just kind of depends, but all in all, bleeding is definitely something to keep an eye on. And then we have our, how do you want to start? Our novel oral anticoagulants. Our DOACs is another term for direct oral anticoagulants. So it just kind of depends on how you might hear them being worded as, but they basically work differently than warfarin. They still work on that clotting cascade, but they're working at different factors. So they either inhibit thrombin or they either inhibit factor 10A. And basically their claim to fame is they have a lot better safety outcomes coming out for their use, a lot less interactions. They can be taken once a day, which is the same for warfarin. And they don't require chronic monitoring with INR. So patients that were unreliable to get it tested and get their dose adjusted, this is a great option for them. The only downside and a plus side is warfarin can take weeks to take full effect, or at least days, but then weeks to maybe titrate to proper INR. These can work within days, within a day, 12, 24 hours even. The downside to that is if somebody's not adherent, then it's out of the system really fast and increases their clot risk. So again, not so much maybe for you guys to preach about medication adherence, but definitely something that they keep up on with this class. And also something to consider of whether or not they continue or stop prior to procedure. And again, why I mentioned usually more often than not, unless it's really significant, they'll continue their anticoagulation just because of the risks. But bleeding is a concern. Downside I have here, which I'm actually going to possibly remove here eventually, because limited reversal agents, so warfarin is reversed with vitamin K. So if you have too high an INR and you're bleeding profusely and you can't stop, you would give vitamin K, and then that would reverse it. But for the longest time, these classes of medications had no antidote, but that is not the case anymore. There's been medications that have been created now that do reverse these medications, or you can give fresh frozen plasma or other blood products to slow a bleed. So that's less of a downside these days than it used to be. So as I mentioned, most dental procedures won't require discontinuation of either an antiplatelet or an anticoagulant. The benefit just does not outweigh the risk. But if you're having like multiple tooth extractions or something that's considered high bleed procedure, then they may recommend that they discontinue warfarin, and sometimes up to 5 days prior to surgery, because it takes warfarin such a long time to take effect because it has a long half-life. And it also takes a long time for it to leave the body. So they'll usually be shooting for a close to normal INR, so less than or equal to 1.4. Normal INR is 1. And so they're slightly anticoagulated, but not so much that they might be at a high bleed risk. And then since the newer agents have such a fast onset and offset, if they do need to stop, sometimes they can at least stop it closer to the procedure. So there's less time frame of potentially not anticoagulated or at increased risk for a clot. And so that is sometimes a benefit for those as well. And in other cases, they may choose to bridge with heparin, which can be quickly dosed, titrated, and taken off and corrected if a bleed occurs. So a couple options there. Again, likely might not be something that your office has recommended. It might be advised by their provider, but just some things you might see as you're in practice. And that is all with 1 minute to spare. Dang, it went.
That was really good timing.
Yeah. I was trying to add the stopwatch up, but my phone just kept turning off, so I was a little blind.
Well, they do have a class. I know they all have a class at 4. Do you guys have any questions for Dr. Begert at all? I hate to offer it up without your permission, but can they email you if they had any questions?
Yeah, absolutely. Yeah, more than happy to answer any questions that anybody might have. I think it's on the front of this presentation, but I can give that back to you if you need it.
Oh, we have it in the Moodle page. They have the PowerPoint. Thank you so much for coming. We really appreciate it.
Absolutely. Thank you guys. It's always a pleasure.
Awesome.
Don't hesitate to reach out.
Thank you. Have a great afternoon.
Yeah, right. It's almost that time.
Yep.
Bye.
Bye, guys.
We're done, Leslie?
Yes.
Okay, thank you.
Yes, you're welcome.
Leslie, can I talk to you for a minute?
Yeah.
We don't have to know that in that much intensive intelligence, right?
You need to know everything he said.
My brain started to shut down. I was like losing understanding. I was like, oh my gosh.
Mostly what you guys need to pick from that is the medications and major dental implications, and then what the medication is for. So if it's, you don't have to know the mechanism of action per se, but you do need to know like all the if it ends in the allols, what are those? If it's that. Yeah. If it ends in a lull, then what kind of hypertensive medication is that? So you do have to remember that kind of stuff.
Right. Okay. Yeah, totally. I was just like, man, he's really smart. I'm not understanding half of what he's saying.
I know. They're really good, like chemistry mechanism people.